Hello, everyone. Welcome to the podcast. It's Dr. Durst, and I have a special guest in the office today, Dr. Ibrahim. Do you want to say a few words, Dr. Ibrahim?
I'm Dr. George Ibrahim. My practice is Biltmore Restorative Medicine and Aesthetics. I'm in Asheville, North Carolina, and I was a Duke-trained urologist and clinical professor for about 15 years before I started doing this type of medicine. So I do have a lot of experience when it comes to testosterone in men, and I think that's our topic today.
Yeah, that's our topic today. And again, it's kind of changed over the
Mhm,
period of the course of your career, I'm sure.
Very much.
And being in urology, that really, really adds a great, background and foundation to what we're going to talk about, which is testosterone and men. So, when we're talking about testosterone in men, obviously that's a slow decline over time, right? And so, what are some of the most common complaints that you get initially from men with that?
Well, okay, so let's talk about the slow decline because women go through their decline pretty abruptly. They fall off a cliff when they go through menopause. Men peak around the age of 25. And after that, it decreases between 1% to 4% every single year. So if you're a banker out there and you take an average of like 2.5 and you compound that over 30 years, it's half. By the time a man is 50, 100% of men by the age of 50 are at half of the peak levels that they were at when they were in their mid-20s. That's every single man. Yes, if you're over 50, you are half as much testosterone as you had when you were younger. So let's go to the Maserati example I always bring up. Say your dad got you, or your late uncle left you a Maserati when you were 25. You kept it in the garage. You drove it a couple times a week. You kept it up, but you never really got around to putting air in the tires. By the time you're 50, that Maserati's got air in the tires still, but only at half the pressure that it had when it was brand new or 25. You can drive that Maserati, but is it going to perform with air that's half the tire pressure that's supposed to be? No.
No.
All right.
I love his stories. Love them. So he basically will help you understand it in everyday terms. You're great at that. Yeah.
But they've gotten used
Yeah.
to this over time, mushy ride. And by the time they're 60, the tires have only got a third of the air pressure. And by the time they're at the 70s, it's a quarter.
And so how many men have you known to say, I've been to the primary doctor, I've been to my doctor, and they said it was all normal?
Okay, first of all, this drives me nuts. It's one of the first things I taught my daughter, who's a physician. I said, it does not say normal over here. It says reference range. What is the reference range? It's 2 standard deviations around an average. The average is taken from men who are 19 to 39 years old. That's not the population we normally see, but still, 2 standard deviations, if you know statistics, that's 95% of everybody that they tested. Now, that leaves only 5%, 2.5 on the high side, 2.5 on the low. So the lab report doesn't turn to low until you're below 2.5%. So let's go back to the car. What man would drive a car with their crankcase having 3% of the oil that he needs in the crankcase? Because 3% is above the line. It's not going to say low. No man's going to drive a car with only 3%. But too many primary care doctors don't see an L, and so they tell the man you're within normal limits. Again, those limits are not normal. Those are reference ranges.
And further,
well, first
you
of
don't
all,
even want to be normal.
And no, because a normal 50-year-old is at half of the level that he was when he was at 25. And when we were at 25, we weren't deficient in the little blue pill. We could go, multiple times a night.
And not deficient in erections at all.
At all.
Yeah.
So, when a man turns 50 and he needs some help, he's not deficient in the blue pill. He's deficient in what he used to have at 25, which was testosterone.
Correct.
At a much higher level.
So optimal is really what we're talking about. Like optimizing that back to when you were younger.
Or, healthier, have more energy, more vigor.
So that's huge. Erections are a huge complaint. sex drive, not wanting it as often, but energy, brain fog, all those
Oh,
things too.
the mental
Everything's different.
focus, the
Yeah.
productivity that you hear out of
Life
men once they get up.
force.
Yeah.
Yeah, that competitive edge, they kind of lose their zest for life, overall.
Mhm,
But yeah,
mhm,
when you're optimizing,
mhm.
what options do you give them for how you're doing that?
So I'll start off the conversation with the types of delivery for
Hmm.
testosterone. Essentially, there's three types because I don't even consider oral because of the dangers of blood clot. So that's not
Yes,
even.
yeah.
So there's three viable options. And I'll start the way I say it to these men. I go, so there's three options out there, one of which is so useless. I'm not going to talk to you about it other than to say creams are terrible and don't work. And
Don't
then
waste
I
any
go
money.
on.
Yeah.
Yeah. Creams and gels are essentially
Hmm.
useless. Think about this. If the skin does its job is to keep bad things or
Hmm.
anything outside of the body.
Hmm.
All
Yeah.
right. Well, then,
It's
yeah.
just
How's it going to
us
get
in
through
the
it?
outside
Yeah.
world, and it's keeping everything
Yeah.
out. Yeah.
Women can apply it labally. Not too many men are going to apply it anally.
Hmm.
So that pretty much takes creams and gels off the
Hmm.
table. Not even talking about it.
Hmm.
We wasted too much time even talking about it here. So that leaves two methods that I do use: injectables or implants, commonly
Pellets.
called
Yeah.
pellets.
Hmm.
And I start off with this. I go pros and cons of each. Pros of injections, I know it's going to work because I'm going to get through the skin.
Hmm.
Cons, it's going to have a really high peak in the beginning, and then it's going to drop off, and then it's going to be a peak, and then drop off. To some men, that doesn't bother them.
Hmm.
To some men, that's like a roller coaster.
Plus, you get more side effects when you're
Yeah,
fluctuating like
back
that.
up and
Yeah.
down. It's inconvenient.
Hmm.
If you're doing one shot a week, that's 52 shots of a
Hmm.
big long needle with a very thick, literally oil substance. So that can be, a negative.
Hmm.
Implants. Okay. Implants, I know it's going to work because it's going to be in direct contact with the blood supply. It's going to go underneath the skin and the fat. Typically, we'll put it in the buttock or the flank, just some place where there's some fat that I can put it under. It doesn't hurt. The numbing medication might sting, but other than that, it doesn't hurt. The next day, it might be a little uncomfortable. Some guys will say, "Doc, I didn't know you did it unless I bumped into something." Some
Yes.
guys
Yeah.
will complain, say they felt like they got kicked, but men are,
Oh,
whine
and they
much
get a
more
little
than
more
men.
in the way of pellets
Yeah,
too. Yeah.
but it lasts longer in men. These implants are made out of stearic acid and testosterone. Stearic
Hmm.
acid is a natural human fatty acid that's been used in medicine for 80 something years, and it dissolves over time
Hmm.
and at a known rate.
Hmm.
And so over the next few months, we'll go up and down, and that's another pro. The dosing curve is much smoother.
Yes.
The high is
Yes.
never as high as the shot, but it still stays well above the low of the shot for a long time.
Yes.
So
you're going up and staying up, less in the fluctuations,
yeah,
less in side
yeah.
effects. Yeah.
And then I'd say the vast majority of my patients that are new pick implants.
Hmm.
They're allowed in our program to switch at any time.
Between the two.
Yeah,
Yes.
the same
Yeah.
price. The ones that choose injections almost overwhelmingly are coming to me from another practice where they had already been doing injections.
Okay. Yeah.
It's probably 85% of my patients are on implants and 15% are on injections. As far as safety, to me, they're identical. Same
Hmm.
hormone, the same. There's no risk other than bruising.
Hmm.
That's about it.
And from women and men, they get more pellets because their levels are higher. Maybe a
Yeah.
little more soreness, but really.
I mean,
minimal.
I do say to men, especially if I have a couple, a man and a woman in the room, I do look at the lady and I tell her that tomorrow when he's complaining and you're not, he gets to. It's about, in my opinion, a 30-time greater procedure.
Yes.
But he
Yeah.
only has to do it 3 times a year and she has to do it 4 times a year.
Yes. Yeah.
So that's where it evens out a little bit.
Yeah, no, I agree. And really that's it, because that's, the only, and I agree. We don't do creams. I actually don't think I have any
I don't
men
have any
on
men
creams, so
on
I
it.
still will have a couple women that are way back came to us and just won't change, but that's maybe 2. But injections and pellets, and that's it. And again, side effects that you can get with either. Again, I think it's more common with injections, and some side effects, acne and just hair changes.
Yeah,
really.
but those are easily manageable.
Yes, correct. So always you can prevent that. And then I think that
Well, I'm going to interrupt you while you're getting your thought. prostate
Good.
cancer.
Yes. Perfect.
Gone.
Mhm.
In the old days, and this is the truth. I was one of those. I was a
Mm.
prostate cancer expert.
And this is where it's changed over the course of your career.
Totally.
Yes.
And 30 years ago, when a man would say, "Hey doc, while I'm here, can I get a testosterone shot?" And I go, "Hell no. I'm not about to throw gasoline on what might be a prostate cancer fire." Abraham Morgan Taylor is a Harvard-based urologic oncologist, and he was the one that saw the forest for the trees. And I'll skip ahead and not tell all the details, but he's the one that discovered testosterone does not cause prostate cancer. It's just puberty. In fact, low levels of testosterone have higher instances of prostate cancer. So prostate cancer is not caused by testosterone. Now I am the prostate cancer doctor that takes testosterone and writes for it every day.
Yes.
So it's come a long way around.
And I think that's more the exception than the rule still.
Yeah.
But and he actually, went head to head with the traditional model and believing that prostate cancer was caused by testosterone. Kind of did some deep research into those studies that actually ended up not revealing that at all.
Yeah.
But then the accepted norm, it was hard for him to push that onto
it's
acceptance, right? But,
and the vast majority of urologists out there still feel like it does.
yes.
But I'm seeing more men showing up with a history of prostate cancer on testosterone.
Well, I'm also seeing a lot more urologists that are on board for it now, because they'll still send them here, but they're okay with it. And that is that's unusual too.
Now, unless things have changed greatly, we really did not have hormone training as far as managing men with testosterone. Urologists are surgeons, and they're just not comfortable. Yeah.
Yeah, well, it's just like us. If somebody needs surgery in any field, you're going to refer them to a surgeon.
Yeah.
So I feel like if you don't have special training in hormone replacement therapy, you should send them to a specialist that does. Because you see a lot of them dabble, but just not doing it right. That was the other issue that I was going to bring up is I think that the one time, because we do some injectable kind of younger patients that come in from injectable, practices. And so, it's a decent percentage of the younger that will push for injections with us. But if they have erection changes, absolutely pellets across the board. Because if you have erectile changes, it's only a small percentage that's hormone, but you take that fluctuation out of it. And pellets are best, and again, most of your patients are on pellets, so it's not really an issue. But if you have erection changes, I feel like you need to be on pellets.
Yeah.
You need no fluctuation, take that out of it, and then start to regenerate the tissue. And then side effects really are minimal. And so not to worry about it. And prostate cancer would be one of the ones that people are coming in asking about. But I feel like patients are so much more proactive than physicians and providers in this area. And they come in, they've done their research already, even when they've had a prostate cancer history.
Maybe I'm hyper vigilant, but our patients are so closely followed when it comes to prostate cancer that we're so much more aware of it.
Because you're doing blood work way more frequently than traditional medicine. So and then referring them based on standards, right? So, all right. Well, I think that covers it all. So if you have any other questions, drop them in the comments, subscribe, and I want to thank you, Dr. Ibrahim, for being on the podcast, sharing all your knowledge and expertise. And I love the way that you always present it in such a very direct fashion, both with patients and other providers. I love it.
Thank you so much for having me. Like I said, I learned so much when I'm here. Thank you again.
My office staff loves having him here, and his office is amazing over in Asheville. Again, there's a mountain in between the two of us, but otherwise, I love visiting as often as I can, and he's got a beautiful office over there. So,
well, thank you.
All right. So subscribe, and let us know if you want to hear anything else, because we're willing to deep dive into anything sexual wellness, and we're here to revitalize your health and your sex life. Thank you.